So always remember systemic mycosis is you want to remember like the 25 and 37 for everything. Okay, so first we'll be dealing with Histoplasma capsulatum. Okay, so here this there is a species that is in var capsulatum, var debussy and var farsi minosum. Okay, so here the capsulatum causes an classical histoplasmosis, which is the most common type, whereas debussy causes an African histoplasmosis with frequent skin and bone involvement, whereas farsi minosum or farsi minosum, whatever you can say, it is usually causes an animal histoplasmosis. Okay, so here at 25, so always remember, if they are asking histoplasmosis, two terms you want to remember. One, it is in tuberculate macrochondria, so tuberculate, and it can be confused with tuberculosis. Okay, so at 37 it usually produces a tiny oval cell with narrow based body. This 37 and all that much not important, but this specific, that is in tuberculate macrochondria. So blastomycosis here, it is also called as a North American blastomycosis, Gilchrist disease or Chicago disease. So remember B. So B is like 8. So it is a figure of 8 appearance. That is, it has a single broad based budding will be there. Okay. Next, coccidiomycosis. Here you want to remember what are the other terms like desert rheumatism, valley fever, California fever. Here you will be so yeast form, that is, spirules will be seen. Again, spirules I told in rhinosporidiosis, and in culture it usually shows an barrel-shaped arthrospores. Okay. So paracoccidiomycosis, always you want to remember Mickey Mouse appearance and the pilot wheel appearance. So these are some of the other names. Just I have North American blastomycosis, that is called as a blastomyces dermatitis. Paracoccidiosis immitis, it is also called as a South American blastomycosis. European blastomycosis is also called as a cryptococcus. So next topic, it is an opportunistic mycosis. So first, it is a candidiasis. So what is the most common? There will be these are the disease which is caused by candidiasis. First, it is an oropharyngeal candidiasis, and then vulvovaginitis. Here, there is a specific term. If they are giving a candida history, it is a curd-like discharge. Next, it is in balanitis and balanoposthitis, usually seen in the uncircumcised males. And esophageal candidiasis and angular stomatitis, denture stomatitis, and chronic mucocutaneous candidiasis. This no way just you want to by heart that. So here, what is the test specific for Candida albicans? Okay, so first it is in germ tube test will be positive, and Dalma plate culture usually produces in chlamydospores. Chrome agar produces in green color colonies, and there will be growth at 45 degrees Celsius, sugar fermentation and sugar assimilation test. So just remember these are the tests, but the most important test is germ tube test. Okay, so if it is if you come across these points and if they have given this lot of positive, means it is a condition which is favoring for Candida albicans. So next, what is the treatment? So here the cutaneous candidiasis or oral thrush, it is a topical azole. If you are coming across esophageal or vulvovaginal, again it is in fluconazole. Always remember, whenever there is a disseminated, there will be an amphotericin. So these are Glabrata and Cruci, they are intrinsic resistant to azole. So they are usually, the treatment is unsatisfactory. Okay. So next, it is in Cryptococcus. So here there is a two species you want to remember. One, it is in var grubi, that is present worldwide, whereas gatti, it is present in the tropics. Here, what's the clinical manifestation you remember? First, it is a pulmonary cryptococcosis and meningitis. Okay, and skin lesions is usually seen with some of the serotype D and osteolytic bone lesion. But if you are coming across cryptococcus, you want to remember these two, that is in meningitis and the pulmonary cryptococcosis. So always in SDA it will be producing creamy white yeast-like colonies. Right? The same. Candida also produces the same, but on gram strain in cryptococcosis there won't be any pseudohyphae, whereas Candida there will be in pseudohyphae. So here Niger seed agar or bird seed agar usually produces a melanin production, and it will be growth at 37 degrees Celsius and urease will be positive. Okay, so here you want to remember this point, that is a Niger seed agar and the birdseed agar. So what is the treatment here? It is, if the patient is without CNS involvement, you can go for fluconazole. But if there is a HIV patient with CNS involvement, you can give with the amphotericin and flucytosine and followed by lifelong therapy with fluconazole. So friends, I'm saying again, I have posting only the important points only, okay? So you must not leave a single point from this video. So next, coming for Aspergillosis. So here we'll be dealing with three species. One, it is Fumigatus, Flavus and Niger, okay? So here, so most common human disease caused by Aspergillosis is automycosis, okay? If it is an invasive form, it is in lungs. If it is disseminated from the lungs, the site is brain. So if it is get disseminated from the lungs, and it will be going into the brain. So cerebral aspergillosis usually presents with an hemorrhagic infarction. So aspergilloma is usually caused by Aspergillus fumigatus, but in diabetic patients is caused by Niger. Okay, so whenever there is a sinus aspergilloma, it is usually limited to the maxillary sinus. So what is the lab diagnosis here? It is only it is in direct microscopy, that is you can make out, this is the important point. It will be having a narrow septate hyphae with acute angle branching. So whereas zygomycosis, it will be having a wide angle branching. Okay. So next you can go for culture or it can be KOH mode. Oh, here treatment is, I told already. So first, whenever they are coming for an invasive aspergillosis, voriconazole. If allergic bronchopulmonary aspergillosis, it is an itraconazole. If it is a single aspergilloma, just surgery. If in case of chronic pulmonary aspergillosis, itraconazole or voriconazole. For prophylaxis, we can give the posaconazole or whatever. But I think you want to remember these are the basic drugs you want to remember. So here macroscopy appearances. So fumigatus, always remember smoky green, okay? Because just remember that word is enough, smoky green, okay? So fumes, it all will be like a smoke, just remember like this. And fumes, you know in house there will be chimneys. So the fumes will be going in one direction. So it is usually present only in the upper third, okay? Vesicle is, conidia is usually arises from the upper third of a vesicle. Whereas flavus, the conidia will be over the upper two-third, okay? Whereas in Niger, it will be present over the entire conidia. So here flavus, you want to remember it is an yellow-green color. Niger always black color, okay? So fumigatus, smoky green, and conidia will be present only in the upper third. Flavus, it is an yellow-green and it is usually present in the upper two-third, okay? But Niger present over the entire. So friends, I have the another video like how to identify the fungus. So what's the clinical, what is the key points that I will be posting in the link, description box. Kindly go through that, because I didn't post any pictures over here. So I will be posting in that video. You go through that. So coming for next family, it is Psychomicmicosis. So there are two order. One is a mucorales, it is in rum, Rhizopus, Absidia and the mucor, and entomophthalus, it is in Basidiopolus and the Conidiobolus. Here pathogenesis is 4D. One is diabetic ketoacidosis, desferoxamine therapy, end-stage renal disease, and defect in the phagocytic function. So 4D you want to remember here. So pathogenesis you can remember like head to toe symptoms, okay. So first it is a disseminated brain. Next rhinocerebral, pulmonary, gastrointestinal and cutaneous. So starting from the head. So it is the most common form here, it is a rhinocerebral. Second most common, it is a pulmonary. So how to so the pictures I have posted in that video, okay. So I'm just descriptions I am giving here. So first Rhizopus, Absidia and mucor. So always remember Rhizopus, it is in salt and pepper appearance due to sporulation. Absidia, white colonies, mucor, white colonies. The specific term you want to remember here is lid lifters. Whereas Rhizopus you want to remember salt and pepper. Whereas in mucor you want to remember the lid lifters, okay. So coming for rhizoids, rhizoids name itself implies so rhizoids will be present. Whereas Absidia, it is an internodal, okay. So because this having a 2I, so it is an internodal. Mucor, absent rhizoid. So that is a clinical key feature for the mucor. There won't be any rhizoids. So here I told no aseptate hyphae with wide angle branching. Whereas Aspergillus, it is a septate hyphae with a narrow angled branching, or it can be an acute angle branching. So treatment, always you remember, so mucor, it is an amphotericin B. Okay. If it's a mild or which can be removed surgically, but the drug of choice here, it is an amphotericin B. So coming for next, it is a pneumocystitis. So friends, you can remember like pneumocystitis, right? So first one, it is a it is a plasma cell pneumonia. So it causes a pneumonia. The typical feature is frothy exudate in the alveoli. Next, OC. OC is for, you can remember like cotrimoxazole, it is a treatment. Cyst, so it will be having a cyst. So that cyst, you will be using a gomari methenamine stain. That will be having a typical crushed ping pong appearance against a green background. Okay. So you want to remember this. The tropozoites also will be there, but mostly the cyst is usually identified. So this pneumocystitis, you can just break the word OC, cyst. Okay. OC for cotrimoxazole and cyst for cyst, which is the crushed ping pong appearance against a green background. So that's a typical feature. Okay. So just a mnemonic so that we can remember it easily. So coming for penicillium monophy, you can remember like A, B, C, D, E. So A for amphotericin B and B for brick red pigment. C for it usually spreads by inhalation of the conidia, and D for it is a dimorphic fungus, and it is the most common cause of opportunistic infection in HIV patient. Okay, just remember A, B, C, D, E. But here the specific important term is a brick red pigment. Okay. Coming for fusarium. So this is it will be very actually easy, okay, because it will be affecting all the patients, immunocompetent, immunocompromised, or neutropenic. So when it's coming for immunocompetent, they usually causes an keratitis in contact lens virus and onychomycosis. So again, what is a parasitic infection in contact lens users? It is mainly caused by acanthamoeba keratitis. So immunocompromised patient, it is usually angioinvasive and causes a pulmonary and sinus infection. Whereas hematological malignancies, that is neutropenic patient, it will be presenting as disseminated because they are very severely immunocompromised. So they presents with the disseminated lesions. Next, what is a lab diagnosis? Always remember, if you are coming across fusarium, there is a sickle cell shaped macroconidia. So treatment here, it is a that is an amphotericin B, uriconazole or posaconazole. So whatever can be given. If we are asking fusarium contact lens user, it can affect all the type of the patient individuals and sickle shaped macroconidia. So this term is important, friends. You want to remember mycotoxicosis. So mycotic poisoning can be two varieties. One, it is a mycotoxicosis. Another, it is a mycetism. Okay. So mycotoxicosis is by what is that? The consumption of the food which is contaminated by the fungus. Okay. But mycetism is you are directly eating a poisonous fleshy fungus. Example, mushroom. Okay. Mycotoxicosis is food. The food which have been contaminated by the toxins. Whereas mycetism is the mushroom. That is an what is that? The poisonous mushroom which we are eating that can lead to the deleterious effects.